My name's Dominic Power. I'm a consultant hand and peripheral nerve surgeon based in Birmingham in the UK and one of the editors for OrthOracle, Hand, Wrist and Peripheral Nerve. This short talk is about my indications for expiration and decompression of an injured peripheral nerve. The clinical diagnosis after nerve injury is based on the patient's symptoms, usually neuropathic pain, a strong TNL and altered autonomic function in the territory of a nerve imply that there is axonal damage. Neuropraxia is a commonly misused term, which effectively means a nerve is not working, but implies that there's no structural damage. If the patient has neuropathic pain, a TNL at the site of suspected injury, and autonomic disturbance, with loss of all modalities within that nerve, including deep pressure awareness, then usually a diagnosis of neuropraxia is wrong, and the patient has an axonopathy. They have axonal damage and either an axontometic injury, as popularized and described by Seddon, or neuroontometic injury, where the nerve is transected. The role of the peripheral nerve surgeon is to define the anatomical location of a nerve injury and the pathophysiological grade or depth of nerve injury, and using these, decide on whether a nerve expiration is warranted. I use a very simple description known as the Ds to make a decision about whether a nerve needs to be explored. A nerve may be exposed for diagnosis, particularly where there is uncertainty. If there is a large hematoma and disordered function in a peripheral nerve, then decompression is necessary and the nerve should be exposed. If there's a displaced fracture fragment in the line of a nerve that's not working, then the fracture should be reduced, stabilized, and the nerve exposed and decompressed. If a diagnosis of a neuropraxia is made, but the patient develops dry skin or debilitating neuropathic pain, or has a deepening of the nerve lesion under observation with further loss of function, then these are all red flag symptoms that should prompt expiration of the nerve. And finally, if there is a delay in recovery or doubt. So a surgeon has potentially diagnosed a lower grade nerve injury, but the patient is following a trajectory without improvement and progression of a TNL, then this implies that something is unhappy around that nerve and the nerve should be visualized, and this warrants expiration. So in summary, using the Ds is a way of deciding whether a nerve needs to be exposed and visualized, and it's a useful aid memoir for peripheral nerve surgeons.